Welcome, everyone, and thank you for joining this evening for translating guidelines into practice, management of patients with varicose veins of the lower extremities. Our goal today is to present the latest clinical practice guidelines based on systematic review and meta-analysis of the available scientific evidence. We will review results of percutaneous venous ablation procedures, talk about advantages and indications for compression therapy, and we will discuss the current role, if any, of open surgery for treatment of varicose veins. The session will compare outcomes after concomitant versus staged interventions for the treatment of saphenous incompetence and associated varicose veins, treated with sclerotherapy or with mini-phlebectomy. I'm joined today by my co-moderators, Drs. Peter Lawrence from UCLA Medical Center in Los Angeles, California, and by Dr. Suman Vasan from UNC Health in North Carolina.
Thank you, Peter. As you mentioned, our faculty today will cover the latest clinical practice guideline. Our presenters will address diagnostic evaluation of patients with varicose veins using duplex scanning to confirm pathologic superficial truncal reflux. The faculty will use a case vignette to design treatment strategies and demonstrate how to put the recommendations from the evidence-based clinical practice guidelines into practice. The pre-survey that was launched a few moments ago will be followed up with another survey toward the end of the webinar, and a final follow-up survey will be followed up 60 days later to gauge and evaluate if the guidelines were easy to translate into your clinical practice.
Thank you, Peter. This session will be helpful in expanding the physician knowledge base and improving clinical confidence and effectiveness in treating patients with varicose veins. The session will also cover drug therapy and nutritional supplements for patients with varicose veins, and we will discuss in detail how to treat patients with superficial vein thrombosis. The pre-survey that was launched a few minutes ago will be followed up with another survey towards the end of the webinar, and an evaluation survey will follow 60 days later to gauge and evaluate if the guidelines were easy to translate into your clinical practice.
Excuse me, doctors, again, just to talk about that pre-survey, if you have not yet completed that, we do ask that everyone please does that now. And again, we'll compile the results and compare them to a post-test that we'll ask everyone to take at the conclusion of the webinar. Thank you.
Okay, let's get started. Our first presentation is from Dr. Mark Meissner from the University of Washington in Seattle. Dr. Meissner is a Peter Glovitsky. That is the same Peter Glovitsky who is moderating today, professor of venous and lymphatic disorders at the University of Washington Medical Center. He's the past president of both the American Venous Forum and the American Vein and Lymphatic Society, and the past secretary general of the International Union of Phlebology. He's published over 130 peer-reviewed manuscripts with research interests, including the natural history of acute deep venous thrombosis and evidence-based venous disease. Dr. Meissner joins us now with a pre-recorded presentation entitled Diagnostic Evaluation of Venous Incompetence. Dr. Meissner.
Good evening. My name is Mark Meissner from the University of Washington, and tonight I'm going to be talking about the new guidelines regarding the diagnostic evaluation of venous incompetence. I have no disclosures. We'll start with the case of a 14-year-old girl referred with a 1-year history of right lower extremity heaviness and discomfort. On physical examination, she had no visible varicose veins, no edema, and no other signs of venous disease. Her family history was negative for venous disease. She'd undergone an outside duplex examination, which on the report suggested that the exam was done in either a standing or reverse Trendel inverted position, although on questioning the patient and her family, it was clearly done in the supine position and demonstrated reflux throughout the deep venous system, as well as the great saphenous vein on the right, and reflux in the femoral vein and in the great saphenous vein in the calf on the left. The outside facility had recommended ablation of the right great saphenous vein, and her family now brings her in for a second opinion. We repeated the duplex study in the standing position using a distal cuff deflation method, which in contrast to the outside study demonstrated no reflux in the common femoral vein, the femoral vein, or the great saphenous vein. So what went wrong here? Duplex ultrasound is clearly the diagnostic gold standard for the detection of valvular incompetence, where reflux is defined as retrograde flow in response to a provocative maneuver. However, from a diagnostic standpoint, the criteria depend on a number of factors, including the defined cut point for the definition of pathological reflux, the provocative maneuver utilized, and patient position, supine, reverse Trendelenburg, or standing. To understand what went wrong, we must have some understanding of the mechanism of valve closure. With normal antegrade flow, the venous valves are open, as shown here. Valve closure is initiated by reversal of the normal transvalvular pressure gradient. As this pressure gradient gradually increases, there is initially a short period of retrograde flow or reflux until the gradient becomes sufficient to cause valve closure. More than simply cessation of antegrade flow, valve closure requires retrograde flow of sufficient velocity to completely coapt the cusps. The velocity required to ensure complete valve closure appears to be 30 centimeters per second. At velocities less than 30 centimeters per second, reverse flow may persist for longer intervals, even in the presence of competent valves. The determination of valvular incompetence therefore requires that pathologic retrograde reflux be demonstrated in response to maneuvers that consistently generate an adequate reverse flow velocity. Such retrograde flow velocities are usually achieved in the upright position, although may be inadequate in the supine position. Standardized testing using pneumatic cuffs is the most technologist-friendly and most reproducible way of detecting reflux. This scattergram illustrates the segmental results in the 30 normal extremities examined by Van Bevelen using a distal cuff deflation method designed to produce retrograde velocities greater than 30 centimeters per second. Using this method, 95% of normal valves will close in less than 0.5 seconds, allowing reflux to be quantified. Nikos Labropoulos similarly evaluated a larger group of both patients and controls using a standing cuff deflation method. For all segments examined, mean reflux times in the superficial perforator and deep veins of patients were significantly longer than those of controls. Based upon this data, optimal reflux duration cut points for distinguishing patients from controls were 500 milliseconds for the superficial veins, greater than 1,000 milliseconds for the femoral and popliteal veins, and greater than 350 milliseconds for the perforating veins. He also found that reflux assessment in the supine position leads to both false positives and false negatives. Among 10 patients evaluated in both positions, reflux was falsely positive in 12% of patients in the supine position and was absent, that is, falsely negative, in 7% of segments with reflux in the standing position. False negatives are presumably related to a lack of dependent venodilation in the supine position, while false positives presumably result from failure to generate an adequate reverse flow velocity. False positives are likely a much bigger problem than false negatives in the supine position, as was the case in this young girl. The INVEST study investigated the repeatability of duplex ultrasound for the determination of reflux in 17 healthy volunteers and 57 patients with chronic venous disease. Study parameters, including time of day, position, and provocative maneuvers, were varied in the evaluation by a single technologist. On average, reflux times were significantly shorter in the standing compared to the supine position. Repeatability, as measured in seconds, was better in the standing than in the supine position, and the best repeatability was achieved in the standing position in the morning. And the new multi-societal guidelines endorse duplex scanning as the diagnostic test of choice for venous reflux as a grade 1B recommendation. Further, as implementation guidelines, they establish diagnostic thresholds for defining reflux of greater than 500 milliseconds in the superficial veins, greater than 1 second in the common femoral, and popliteal veins, and in combination with a diameter of greater than 3.5 millimeters, reflux duration of greater than 500 milliseconds in the perforating veins. Furthermore, evaluation in the standing position is recommended whenever possible, as provocative maneuver, either a Valsalva's maneuver or distal compression are recommended proximally, and distal compression for the more distal segments. The examination should also include measurement of spectral Doppler waveforms using calipers. The guidelines also recommend that diameter measurements be made with the leg in a dependent position. However, it is important to note that isolated diameter measurements poorly correlate with the degree to which a patient's quality of life is impaired or with improvement after superficial venous intervention. For example, in this systematic review of 11 studies evaluating the relationship between saphenous vein diameter, clinical severity, and health-related quality of life, all 8 studies evaluating SEEP have found a correlation between vein diameter and C-class. Similarly, among the 5 studies evaluating VCSS, 4 found a correlation, although often weak, between vein diameter and VCSS. However, none of the 4 studies evaluating a variety of quality of life instruments found any relationship between vein diameter and quality of life. As chronic venous disease is most often a quality of life disease, the authors concluded that using vein diameters as a surrogate measure to limit access to care is inappropriate and ineffective. So to return to our 14-year-old patient, in conclusion, duplex ultrasound is the gold standard for the diagnosis of venous reflux, but it must be performed and interpreted correctly, and by itself is not a license to intervene. The 2022 multi-societal guidelines have been a paradigm of collaboration and have established diagnostic thresholds of greater than 500 milliseconds for the superficial veins, perforators, deep femoral and tibial veins, and greater than 1,000 milliseconds for the common femoral, and popliteal veins. As examination in the supine position is less reproducible and may be associated with both false positive and false negatives, the examination should be performed in the upright position whenever possible. And lastly, the duplex examination provides invaluable information, but is not a license to intervene and must be interpreted in the context of the clinical presentation. Thank you very much for the opportunity to participate and for listening tonight.
Thank you very much, Dr. Meissner. This was an excellent and very important presentation, and I'm sure you are going to have several questions from our attendees at the end of this session. Our next video is being presented by Dr. Andrea Obi from the University of Michigan. Dr. Obi is an assistant professor of vascular surgery and has a long-standing interest in disorders of thrombosis. Her laboratory focuses on defining the role of immune system in acute deep vein thrombosis and its sequelae. And long-term goal is to uncover mechanisms responsible for idiopathic and sepsis-related DVT and to identify new targets for therapeutic intervention. The presentation of Dr. Obi is titled Compression Therapy for Varicose Veins. We will now hear from Dr. Obi.
Thank you for the opportunity to present today. These are my disclosures, none are relevant to the talk at hand. So I'll start with a patient case. This is a 69-year-old male who presented to my clinic with symptoms of heaviness, achiness, and pain, which is worse at the end of the day with standing. And the location of his symptoms were predominantly over this large pretibial varicosity highlighted by the arrows on the right. His duplex showed deep reflux in the common femoral valve only, and then axial reflux of the entire great saphenous vein, which was feeding this tributary bed. So key questions for this patient as they relate to compression. What role does compression therapy play in the initial treatment of venous disease? And secondly, how should compression therapy be managed following a venous intervention? So we'll tackle this first question first. So just as frame of reference, throughout this talk, we'll talk about different classes or grades of compression therapy. And depending on where you're located in the world, these definitions may vary. So as we talk about class 2 and class 3, what we're really referring to is the USA standard, which is 20 to 30 millimeters of mercury and 30 to 40 respectively. So data on compression therapy as the initial and sole treatment of varicose veins was recently analyzed in a Cochrane review where data from 13 randomized controlled trials was compiled. And what I've done is I've highlighted for you the 4 major findings of this trial. So 9 of the studies reported that patients who were treated with compression had subjective improvement in symptoms. I put a little asterisk there because these patients weren't necessarily compared to the control group in every trial, so the certainty of these findings is unclear. Secondly, a couple studies looked at physiologic findings such as ankle circumference. However, these findings were inconsistently affected by stocking use, meaning that it's impossible to understand whether physiologic findings are reliably changed by compression therapy. Thirdly, there are wide variations in compliance observed in these randomized trials, some reportedly as low as 37% and others very good, suggesting that this may be an issue for patients who are prescribed compression, but on the other hand, a severe complication rate was very low. And finally, little to no difference in outcomes between different types of stockings or grades of compression was seen. This led the authors to conclude that there is insufficient high certainty evidence to determine whether or not compression stockings were effective as a sole or initial therapy in patients with varicose veins, or whether any stocking type in terms of the grade of compression or the length was superior to any other type. So if stockings are of uncertain benefit, then the question really becomes, for this initial treatment, should patients undergo compression therapy or surgery for C2 disease? And this question has been attempted to be answered by now a few randomized controlled trials, the results of which are summarized on the left-hand side of the screen. And what has been found to be true in each case is that when patients are randomized to compression therapy over a period of many years, they tend to have overall worse quality of life, worse venous-related symptoms, and ultimately compression stockings end up being not as cost-effective in the long-term treatment. So because of these reasons, this recommendation was given in the most recent guidelines for patients with symptomatic varicose veins and axial reflux and the GSV or SSV who are candidates for intervention. We recommend superficial vein intervention over long-term compression stockings. Now, the corollary statement, so in patients who do have underlying medical factors that may make it difficult or impossible for them to undergo venous intervention, or they may not have, they may not walk, or they simply prefer conservative treatment, given that stockings are certainly not harmful, and indeed there's some evidence that they may be helpful, the recommendation is given that compression therapy could be used as primary treatment, but that's given a lower grade of recommendation, a 2C. So let's move along to the second question. How should compression therapy be managed following a venous intervention for this patient? Let's talk a little bit about compression after thermal axial ablation, which has now been studied in several trials. You see summarized over on the left is results from one recent meta-analysis, looking at the results of some of these trials in terms of compression versus no compression, and then different durations of compression. A few major themes have emerged from these RCTs. The first being that early postoperative pain and early return to normal activities is improved in patients who are treated with some sort of compression dressing. However, when you parse through the data and you look at the patients and the type of procedure they receive, this benefit is seen primarily in patients who undergo endovenous laser ablation and or some sort of phlebectomy alongside it, including high ligation and stripping, and that the benefit really is unclear for radiofrequency ablation. In terms of type of compression that should be used, if you are using compression, there's really some nice data summarized in this 2019 document. You can see highlighted over here on the right. The first author is Dr. Lurie. And among 6 different trials that were summarized in this document, all of the trials used at least a class 2 compression or above, and the use of an eccentric dressing in combination with this grade of compression provided the best pain scores at 7 days post-procedure. So using some sort of padding alongside the ablation track or over the phlebectomy sites seems to be the most beneficial. So for this reason, we give this grade of recommendation in the new set of guidelines in patients undergoing thermal ablation for saphenous incompetence with or without concomitant phlebectomy. We suggest post-procedure compression therapy for a minimum of 1 week for pain reduction. And that's all I have. Thank you very much.
Thank you, Dr. Obi. As a reminder to our attendees, please use the Q&A button at the bottom of your screen to submit your questions at any time for any of our presenters. Now we'll hear from Dr. Monica Glavitsky, Research Fellow Emeritus at the Mayo Clinic Gonda Vascular Center in Rochester, Minnesota. Dr. Glavitsky studied medicine both in Warsaw and in Paris, where she earned her MD and PhD degrees. In Paris, she worked in vascular research at the Servier Laboratories for 15 years, developing drugs for venous and lymphatic diseases. She joined Mayo Clinic in 2007, worked at the Gonda Vascular Center, and as a research fellow in the Department of Internal Medicine, where she received the Outstanding Research Fellow Award. Dr. Glavitsky is a prolific author and editor. She was assistant editor of the 3rd and 4th editions of the Handbook of Venous and Lymphatic Disorders, and is an active member and distinguished fellow of the American Venous Forum, serving on the Venous Ulcer Guidelines, Lymphedema, and Varicose Vein Guidelines Committee. With a presentation titled Drug Therapy for Varicose Veins, we will now hear from Dr. Monica Glavitsky.
Good evening, and thank you very much for inviting me to talk about drug therapy for varicose veins. Here is my disclosure, and I will start by stating that most of the scientific societies recognize the evidence-based mode of action of the main venoactive drugs and recommend them for the relief of symptoms and edema associated with chronic venous disease. Recently, European Society for Vascular Surgery recommended for patients with symptomatic chronic venous disease who are not undergoing interventional treatment, are awaiting intervention, or have persisting symptoms and or edema after intervention, medical treatment with venoactive drugs. Our committee reviewed the following venoactive compounds: diosmin, micronized purified flavonoid fraction composed of diosmin and hesperidin fraction, ruscus extract, hydroxyethyl rutosides, calcium dobesylate, horse chestnut seeds extract, red wine leaf extract, and surodexide. We concluded that evidence to support efficacy for treatment of varicose veins is moderate for only 2 venoactive compounds: micronized purified flavonoid fraction and ruscus extract. Other compounds had the lower level of evidence, and we consider that they are indeed low of or very low level of evidence. An example of evidence that we could find for MPFF is a meta-analysis of randomized controlled trials versus placebo in chronic venous disease, in which 5 out of 7 RCTs included clearly C2 patients. And the author concluded that based on high quality evidence, MPFF is highly effective in improving leg symptoms, edema, and quality of life in patients with CVD. Another example, the RELIEF trial, which included 40 to 41% of C2 patients and concluded equally on the efficacy of MPFF in quality life improvement and improvement of symptoms. An example for ruscus extract, a meta-analysis of randomized controlled trials versus placebo in chronic venous insufficiency, equally included patients with varicose veins and with the conclusion, based on high quality evidence, Varicose extracts are highly effective in reducing symptoms and edema of patients with chronic venous disease. For horse chestnut, we had found the Cochrane Library review in chronic venous insufficiency, and the conclusion of it was that the evidence presented suggests that horse chestnut is an efficacious and safe short-term treatment for chronic venous insufficiency. Another example for horse chestnut, we had found the interesting study comparing leg compression stocking and horse chestnut therapy in patients with chronic venous insufficiency. For red wine leaf extract, we found a systematic review in chronic venous insufficiency, including 56 studies. And 5 of these trials were only included for the meta-analysis. And conclusion was that red wine leaf extract had a beneficial therapeutic role in patients with CVI. So in our conclusion, for treatment of vein-related pain, leg heaviness, and or sensation of swelling in symptomatic patients with varicose veins who are not candidate for intervention or who are waiting for intervention or have symptoms after intervention, we suggest micronized purified flavonoid fraction or Varicose extracts with grade 2B evidence, and hydroxyethyl rutosides, calcium dobesylate, horse chestnut extract, red wine leaf extract or sulodexide with grade 2C evidence. And this, of course, is the best interest of the patient, the only one to be considered. Thank you very much.
Thank you, Dr. Glowicki, and I'm sure that many of you who are on this webinar might be surprised at the amount of data and evidence about medical therapy and drug therapy for varicose veins and venous insufficiency. The next up is Dr. Jose Almeida, who's an academic vascular surgeon, practices endovascular venous surgery at the Miami Vein Center, Miami, Florida. He's a fellow of the American College of Surgeons and a distinguished fellow of the American Venous Forum. Dr. Almeida has authored numerous peer-reviewed journal articles and textbook chapters on vascular surgery, and he's the author and editor of the Atlas of Endovascular Venous Surgery, textbook published in 2002. He sits on the American Venous Forum Board of Directors and is chairman of the Society for Vascular Surgery, PSO, Patient Safety Organization, Venous Quality Committee. His presentation is entitled Percutaneous Endovenous Ablation of the Saphenous Vein. We'll now hear from Dr. Jose Almeida.
Good evening, and I'd like to thank the SVS for the invite to this Translating Guidelines into Practice, specifically Part 2, Varicose Veins. I'll be discussing percutaneous endovenous ablations of the saphenous veins. I'm Jose Almeida, and I'm sorry if there's a little noise outside, but that's what I got today. No disclosures. So for symptomatic C2 through C6 disease, the reason I put this here is varicose veins are typically the indication for saphenous vein ablation. And just to emphasize, it is not a treatment for C1 disease. It's not a treatment for spider veins. So what's available? Thermal, non-thermal glue, and surgical stripping. Most of you have heard of the two thermal techniques, endovenous laser and radiofrequency ablation. Non-thermals are mechanical chemical ablation and what's called Varithena or polydocanol endovenous microfoam. Cyanoacrylate is a glue. These are the devices below, which probably most people are familiar with. So we'll go through this a little bit. As far as the guidelines and the evidence, 4 points just to discuss. For all saphenous trunks, this is the committee recommendations in the guidelines. Whether it be great, small, inter-accessory, or post-accessory saphenous veins, percutaneous ablation is recommended over high ligation and stripping. High ligation and stripping only if endovenous technology is not available or physician preference. 3, thermal ablation and high ligation and stripping over physician compounded ultrasound guided foam sclerotherapy for patients interested in long-term outcomes. And for saphenous veins in the thigh, thermal or non-thermal is equivalent in the committee's mind. It depends more on physician preference. And the last point for below knee great saphenous vein, non-thermal is gaining evidence as the preferred technique. So let's go through a case. Patient of mine, 80 years old. We ablated her about 10 years ago, right great saphenous vein with radiofrequency ablation, left great and inter-accessory saphenous veins with radiofrequency ablation. She comes in with a rip-roaring recurrence and an ulcer on the left. So just to show, this is not her leg, but just a technique of endovenous laser ablation. We like to use thermal because you can see the actual delivery of the energy under ultrasound, and you can guide the energy delivery based on vein size, tributaries entering the area, or perforators. All these may need more energy. Phlebectomy is our preferred technique for bulging varicose veins. We tend to do this concomitantly with all cases since we treat C2 or above. Phlebectomy is 99% of the time required. We do it concomitantly. And finally, ultrasound guided foam sclerotherapy underneath the ulcer bed. Here's the injection. It's important for that perivenous peri-ulcer plexus for healing. So we typically do all 3 of these at the same time, and that's supported by the guidelines. So considerations when deciding between thermal and non-thermal. 1, is tumescent anesthesia really that bad? We tend to use a little IV sedation and everybody cruises through it. The first 5 years doing this, from 99 to about 03, we did straight tumescent, and yes, some people struggle through it. Since we implemented some mild conscious sedation, it's really just fine. Again, we do concomitant phlebectomy always, and for phlebectomy, tumescent anesthesia is required. So we really don't see the point of a non-thermal when we're going to be placing tumescent anesthesia anyways for the phlebectomy. And again, there's randomized controlled data to support concomitant phlebectomy with ablation. The trade-off, there might be a few more small DVT emphasized, so we'll see some tibial vein thrombus and maybe a couple more thrombus extensions at the junction. Rarely do they require anticoagulation, but sometimes they do for a couple of weeks. Saphenous nerve injury below the knee is a consideration. So if we need to treat the below knee saphenous, we will use a non-thermal. But for the thigh saphenous vein, we tend to prefer thermal. I put here C6 disease. Patients with ulcers already have a neuropraxia in the area, so a little numbness is not as big a deal in these patients, so we may consider thermal below the knee in patients with ulcers. This number 4, physician patient preference, and the reason I put a 2B recommendation. So when 2B recommendations mean that the recommendation is not strong based on the evidence, it's not a 1, and the evidence is moderate. Here, the physician and patient are required to have a dialogue on the best treatments available, as opposed to a 1A recommendation where the recommendation is strong that this treatment is the way to go and not to be likely changed in the future. Large diameter saphenous veins. With thermal, you can deliver more energy. Just to point out here that in the clinical trials comparing thermal to non-thermal, looking for non-inferiority, usually vein diameters of 8 millimeters or less were included. So with large diameter veins, we like thermal and dose the energy higher as appropriate. The safety, efficacy, and adverse events are fairly comparable between thermal and non-thermal, usually self-limited inflammatory type events. There is an upfront capital expense with thermal. You need to buy a generator. So we have all those in the office, so we tend to prefer thermal. If you're new to this game and you don't want to put the capital out there, then maybe a non-thermal where you only need to buy catheters is a consideration. Insurance coverage is limited for non-thermal technologies, whereas most thermal technologies are covered. And someone with multiple allergies, cyanoacrylate is probably not the best choice, as allergies and granulomas have been shown with this technology. So to conclude, my approach is thermal ablation with concomitant phlebectomy and ultrasound-guided sclerotherapy, usually all three of them, 95% of the time. The trade-off is maybe a couple gastroc, and I'm going to call it non-compressibility of the gastroc or tibial veins on ultrasound, because we don't know if it's really sclerosis or thrombosis. The reason I became an ultrasound, got my RVT 20 years ago is to understand ultrasound. And I personally like to look at all these with ultrasound. So I've got a pretty good feeling in the last 25 years of what looks worrisome and what does not. Varithena or polydockel endovenous microfoam or physician compounded foam sclerotherapy for the below-knee saphenous. Unless it's ulcer disease, and I will probably use thermal for the below-knee saphenous. If varicosities are extensive, we like to debulk with phlebectomy, get as much out, and then bring them back for ultrasound-guided foam sclerotherapy 1 month later for cleanup. So that's the evidence on ablation technologies as per the guidelines committee, and a little of my personal approach thrown in. Thank you, and happy to answer any questions.
Thank you, Dr. Almeida. Our next video is being presented by Dr. Peter Lawrence, my co-moderator, professor of surgery at the David Geffen School of Medicine at UCLA, as well as the Emeritus Chief of Vascular and Endovascular Surgery at the Gonda Vascular Center in Los Angeles. Dr. Lawrence has published over 300 articles, editorials, and book chapters related to aneurysms, limb salvage, and venous disease. His textbook, Essentials of General Surgery and Surgical Subspecialties, currently in its 6th edition, is used for the surgery clerkship textbook at over 70% of medical schools. Dr. Lawrence has been president of 6 societies, including the SVS, the Association for Surgical Education, and the Society for Clinical Vascular Surgery. We will now hear Dr. Lawrence's presentation entitled Thrombotic Complications of Endovenous Ablations.
Hello, it's a pleasure for me to talk about one section of part 2 of the clinical practice guidelines. Dr. Glowicki, I know, has given an introduction, but I'm now going to talk about one section which is very important, and that is the thrombotic complications of endovenous ablations. And I have no conflicts. So why are these thrombotic complications of real concern to most of us who do venous procedures? And primarily it's because this is the most important, most severe potential complication following ablation. There can be peripheral sensory nerve injuries and other complications that you've heard about and will hear about, but this is the one that potentially could lead to something like DVT or pulmonary embolism. In addition, it's been only a little over 2 years, almost 3 years, since a classification system of reporting standards was published for EHIT, and we'll talk about that briefly. There's also been considerable debate about the incidence and risk of endothermal heat thrombosis, which is EHIT. In addition, an increasing number of physicians are using non-thermal approaches, and there's very little literature on the risk of thrombotic complications. And therefore, the treatment of both thermal and non-thermal ablations continues to be debated. This is just a screenshot from the publication on EHIT, led by Lowell Kabnick, and I was an author, as many others of you in the audience were. And this is a classification system. This works for EHIT, but as the term implies, it's only been developed for heat-induced thrombosis. Level 1 is an extension just flush with the deep vein. Level 2 is it's less than 50%. Level 3 is greater than 50%, and level 4 is complete occlusion. In these guidelines, we decided to combine thermal and thermal with a new term, ablation-related thrombus extension. The reason we did that is because although the thrombus extension in EHIT with thermal ablation is always been reported to be less than 1.5%, there's very little data on the risk in non-thermal ablation. And in fact, in this study or combination, this slide of 3 different studies shows, if you look at the left column, that it appears that the risk of extension is higher when a non-thermal technique is performed, such as in this case, commercial foam. However, it's also unclear as to how extensive this is, how far into the deep venous system it occurred. So until that time, we really don't have good data on the non-thermal ablation. What are some other potential thrombotic complications following superficial venous ablation? Well, you can have DVT from extension, not through the treated vein, the truncal vein that's being treated, where it extends into the deep system, but through perforators or other collateral veins. There are reports of DVT unrelated totally to the site of ablation, even in the contralateral leg, and also superficial thrombophlebitis associated with these procedures. And Dr. Wasson will talk about that. So with routine duplex post-thermal ablation, in an average risk patient who's asymptomatic, in these practice guidelines, we recommend against routine early postoperative duplex ultrasound with a level 1B of evidence. However, in symptomatic patients, those with swelling pain, we do recommend that there be a post-procedure duplex ultrasound. In other words, symptoms are critical. For pharmacologic prophylaxis, high-risk patients who undergo endovenous ablation, we recommend, as you might imagine, pharmacologic prophylaxis, but with a very low level of evidence. And because of that, it's worthwhile in all your patients asking them about risk factors. Well, what are those high-risk patients? Clearly, prior DVT and hypercoagulable, but somewhat debated would be a very large superficial vein that's being ablated, patients who are morbidly obese, and those of advanced stage. Those last group have not been clearly defined. So what are the recommendations? Well, for isolated distal DVT, such as calf vein DVT after a procedure, that the 2B level evidence is that when they have no symptoms, it's recommended simply serial imaging. For patients who are symptomatic with the same isolated DVT, the evidence is stronger for anticoagulation. For those who have acute proximal DVT in the leg, there's much stronger evidence for anticoagulation using a direct oral anticoagulant. And for patients who are symptomatic with ART, the level 3 and 4, where it extends into the deep vein more than 50%, we recommend anticoagulation. So I'd conclude by saying that, first of all, duplex imaging is not recommended for routine treatment of the truncal veins, but duplex imaging is recommended for symptomatic patients who have thermal ablation. After non-thermal ablations, there's very little evidence supporting either treatment or non-treatment. And for distal calf vein DVT, they can either be observed or treated depending on symptoms. And lastly, those with extension into the deep system, what we now call ART, at level 3 or 4 should be treated with a NOAC for at least 2 weeks or until it retracts. Thanks for your attention. I'll look forward to the discussion.
Thank you very much, Dr. Lorenz. This was, again, a very important and useful presentation because we all need further guidance on the management of ART. as we call it now. Our final presentation this evening is from Dr. Suman Vasan, clinical professor of medicine and UNC Health in North Carolina. Dr. Vasan has been the principal investigator in several research projects regarding chronic venous disease, pulmonary embolism, and deep venous thrombosis. Dr. Vasan is currently serving as a member of the American Board of Venous and Lymphatic Medicine. In addition to her role on the C-Tract steering committee, she also serves as a member of the interventions and venous ulcer committees and serves as co-chair of the medical therapy committee. We will now hear from Dr. Vasan with a presentation titled Treatment of Superficial Vein Thrombosis. Dr. Vasan.
Good evening. As discussed, I'm going to talk about the treatment of superficial vein thrombosis and the guidelines. Here are my disclosures. Let's start with a case. This is a 34-year-old obese white female referred to by her primary care physician. She had long-standing varicose veins and had a left lower extremity great saphenous vein ablation a few years ago on the other side. She works all day as a baker on her feet at Target. Her legs ache and swell. She's very compliant with compression hose, and she was treated with Xarelto 10 milligrams daily. Here is a look at what she presented as. You see on the left a picture of the superficial vein thrombosis, very irritated, erythematous, and was quite painful. On the right, you see the ultrasound findings of thrombus in the superficial varicose veins. So what is the epidemiology of superficial vein thrombosis, or SVT? We know it's more common than DVT and estimated to be about 3 to 8% of the general population. The risk factors are the same as DVT, including immobilization, trauma, surgery, hormonal contraception, obesity, etc., but it also occurs in varicose veins. In general, females are affected more than males. And in the Swiss study, we see that if you look at the natural history, it actually is not benign. In the 3 months in patients who had superficial vein thrombosis, the risk of DVT and pulmonary embolism was 3.4% and remained elevated even up to 5 years after the original event. The problem with SVT is that the presentation is quite heterogeneous. We think of it only in the great or small saphenous veins and tributaries, but it can present in a number of other places, including in the arm, after PICC lines, traumatic, etc. So there is no real standardization in terms of its presentation and treatment. We're going to talk primarily about the truncal veins. So the goals of treatment are very important. We want to reduce or ameliorate symptoms since these patients have a lot of pain with SVT. We want to prevent extension or progression to DVT. We want to prevent pulmonary embolism, of course, prevent recurrence and improve the quality of life. The guidelines are primarily informed by these 4 studies. The first 2 are large systematic reviews that look at all different treatments, including topical, anticoagulation, NSAIDs, compression, and surgical. The last 2 are registries and observational studies that specifically look at SVT approaching the deep veins as well as surgery. So the most comprehensive review of this topic was the most recent Cochrane review published in 2018. As I mentioned, they looked at a number of treatments and found that most of the guidelines could only be informed by one study, which was the Callisto study. So the Callisto study with anticoagulation was a very large study, the largest to date, of over 3,000 patients that were randomized to fondaparinux 2.5 milligrams daily injection versus placebo. These patients had to have at least a 5-centimeter length of SVT, not near the saphenofemoral junction, and the primary outcome at 3 months was death, PE, DVT, and extension with a safety outcome of major bleeding. And as you can see from the schematic on the right, fondaparinux was superior to placebo in these outcomes. Major bleeding only occurred in 1 patient in each group, and so that this has become the standard since it was published several years ago. However, it became apparent that most patients were not going to accept taking a daily injection for 45 days, And so a second study called the Surprise Study that was published in 2017 randomized patients to Xarelto 10 milligrams daily for 45 days versus the standard of fondaparinux. On the left schematic, you see the primary outcomes was similar, and the bleeding outcomes on the right panel were also similar. However, because the study was not powered to non-inferiority, no definitive conclusions could be made, and there was a trend to increase bleeding as well as increased events in the rivaroxaban group. The next study is this one looking at patients with SVT that approached the saphenofemoral junction, and this was a registry review of 225 patients who either received full dose anticoagulation versus what they called preventative or intermediate doses of fondaparinux or low molecular weight heparin, and found again at 6-month outcome that there was no significant difference in the patients who received either arm. They felt that this was hypothesis generating for a trial looking at using lower doses in patients who actually had SVT approaching the saphenofemoral junction. Finally, there is a study that was published looking at urgent surgery versus anticoagulation. Again, this was a prospective observational trial. These patients were again followed out for 6 months, and there was no significant difference in the primary outcome of extension PE or DVT in either group. However, authors did note if patients had isolated non-truncal varicose tributaries, that surgery was a safe option. So what do the guidelines say based on this review of studies? Strong guideline 1A is for patients with SVT of the main saphenous trunks, again, greater than 3 centimeters from the saphenofemoral junction and 5 centimeters in length, that the standard remains fondaparinux 2.5 milligrams daily for 45 days. Since we know many patients will not tolerate injections, rivaroxaban is another tenable choice. The consensus statement is those for patients that approach the saphenofemoral junction and have SVT, full anticoagulation for a minimum of 6 weeks to 3 months should be continued. For patients with SVT of the main trunks, using prophylactic or therapeutic dose low molecular weight heparin and NSAIDs is contraindicated because it has been shown to prevent VTE prevention. If patients have a short segment distal SVT, NSAIDs may be prescribed with surveillance. And for selected patients with isolated thrombosis of the varicose tributaries, phlebectomy may be an alternative. And in patients with saphenous vein thrombosis who have completed anticoagulation, patients may have their source of varicose veins addressed. So our follow-up case presentation, this patient did well. She completed her anticoagulation. She had her vein ablated. She had some tenderness after sclerotherapy, but resumed her conservative measures and did very well. Thank you.
Thank you, Dr. Wasson, for this excellent presentation. And I would like to thank all the presenters this evening. I am now going to ask that they turn their cameras on and join us for a panel discussion. Hopefully, everyone has had plenty of time to add their questions through the QA button. If not, please feel free to do so. We have a large number of questions that came in, and I'm going to start right away, maybe with one question to Dr. Wasson immediately after her presentation. All of us have had patients with varicose veins who recently had a saphenous thrombophlebitis. My question to you is, when should we do saphenous ablation in these patients? What type of ablation should be done? So when to do it and which technique you think is the best?
Yes, that's a great question and addresses the last consensus statement. So if you follow the evidence of how long you should treat an SVT, so patients with superficial vein thrombosis, I will treat them for the full 45 days. At 6 weeks, then I will bring them back for their venous reflux study to see if they what I've called autosclerosed, or they have more proximal reflux that needs to be addressed, or they recanalized on that. At that time, I will do the evaluation and plan the treatment. And someone who has some residual webbing, then I would use a non-thermal technique such as foam. And someone who has more proximal reflux in the GSV or SSV, then I would use typical modalities such as thermal ablation. And then, by the time you get it approved and this and that, it's usually another several weeks. I tend to actually leave them on their preventative anticoagulation through the time of vein treatment. But that's how I approach it. And the reason I give the full 45 days is the earlier studies showed that if you only gave 2 or 3 weeks of anticoagulation, despite symptomatic improvement, there was a rebound effect, and they actually extended after you stopped it. So that has been my experience, and I think supported by the literature, but I'd be happy to hear others' opinion.
Thank you very much. I think we have so many questions that I would like to answer as many as possible. And we have several to Dr. Meissner. For instance, David Cohen, one of our attendees, would like to know what to do with saphenofemoral junction reflux with Valsalva. Mark, it looks like this reflux, junctional reflux, is very common. And what's the significance of this if we do not have more distal reflux?
Well, number one, I think you have to go back to the patient's presentation. What is the patient coming in complaining of? In general, junctional reflux that's very isolated to the junction, we don't treat. But the second question is, where is that junctional reflux going? Is it going to, if it's not going into the great saphenous vein, is it going into the anterior saphenous vein, or is it going into the branches at the saphenofemoral junction? So I personally don't treat that, but I will figure out why that reflux is there. If it's not going into the saphenous vein, where is it going?
It has to go somewhere, right?
And you should be able to sort that out with ultrasound. It's not a matter of just putting the cursor at the saphenofemoral junction and saying there's reflux. It's a matter of tracing, like we do for varicose veins every day, or C2 disease every day, tracing where the reflux is going, and probably won't need to be treated.
Mark, I have several questions here about vein diameter. Everybody has to measure the vein diameter, and you just told us that it really is not very useful to make a decision on ablation.
Well, it's certainly not useful as a single number, like anything else in medicine. To take a number and say we treat, we don't treat based on a number makes no sense. So I think you should measure saphenous diameter and correlate it with the patient's clinical presentation. As I showed in the one slide, if you look at the relationship between vein diameter and C class, it's very high. So patients with higher degrees of C classification tend to have bigger varicose veins. Those are bigger saphenous trunks. Those with C2, C3 disease, smaller saphenous trunks. And so I think it's a clinical judgment made in conjunction with the patient. If it's a 3 millimeter saphenous vein in a patient with an ulcer, that probably is clinically relevant. I tend to follow a little bit of the Aspall principles in patients with very small diameter saphenous veins. That is, if you have less than a 400 millimeter vein, if you're female and you've been never pregnant, about 70% of those will reverse with just doing a phlebectomy alone. And again, there's a role for shared patient decision-making in there to say, we have the option of ablating this saphenous vein versus doing phlebectomy alone in a patient with C2 disease. There's a higher chance that you'll have a recurrence, but a 60% chance that that vein may normalize. What's your choice of what you want to do? So diameter should not be used in a vacuum, I guess, is the fundamental message there.
All right. We have a lot of questions about compression therapy. Dr. Obi, why do different insurance companies give different criteria for the time you need compression before a procedure? And Nilesh Balar asked here, especially for patients with class 5 and 6 disease, why do you need a period of 3-month compression before an intervention? How do you answer that?
Well, I think the straight answer is that those patients, especially the ones with C6 disease, shouldn't have a trial of compression because we have excellent data showing that intervention decreases the time to ulcer healing and decreases ulcer recurrence. So to answer the question of why do insurance companies have different waiting periods for patients with C2 disease, I think that's a really hard question to answer. Being on the other side of things, I think that probably has a lot to do with the business of running an insurance company and doesn't maybe necessarily reflect the data we have from randomized controlled trials.
The other question concerns about the strength of compression. Do we have to prescribe class 1, class 2, or class 3 compression stockings? And is there a role for thigh-high versus knee-high compression? How do you answer that?
Yeah, that's a great question. And I can tell you what my practice is. I use mostly class 2 compression, and that also has to do with some of the insurer requirements that are local to our area, but it also does seem to be a class that most patients tolerate quite well. There is definitely a role for thigh-high compression, and particularly with patients who have thigh varicosities or varicosities that run behind or over the top of the knee, where knee-high compression can cut into them and actually make it more uncomfortable. We've found with patients that you just have to work with them to find a stocking that they can be compliant with, and compliance is probably more important than the class or grade of compression or the length of the stocking. So whatever you can get them in that is comfortable for them. And we've even used inelastic stockings such as ComproFit for patients who have difficulty putting on the regular stocking, or help get them aids such as gripper gloves or a Don and Duffer to help. So basically, to summarize, whatever works for their lifestyle is best.
Dr. Obi, just one more question from an anonymous attendee. Do you prefer any specific brand of elastic stockings?
No, I don't think I can say that in a public forum.
Thank you, Dr. Obi. Excellent answer. I will ask
Dr. Glowinski, could I just ask Dr. Obi to clarify for those who don't remember class 2, because you said above class 2, what those numbers are, what they order when the patient goes into the pharmacy.
Right. So the class of compression starts the lowest being class 1, and then moderate compression be class 2. And I think that's probably what's most commonly used in C2 patients. And that's 20 to 30 millimeters of mercury. And then class 3 is 30 to 40 millimeters of mercury.
Thanks.
All right. Before I give it over to Dr. Lawrence, there is a question from Rahendra Patel to Monica Glowinski. How can one get MPFF and Ruscus?
Well, you have several products available on Amazon.com. Unfortunately, in the United States, all these medications are available only as a nutritional supplement and not medication. Some of pharmacies have now those products on their lists. So it's worth to check with your local pharmacy if they have this type of the compounds.
It is fair to say that it is always useful if a physician recommends these products. Don't you think so?
Oh, of course, you know, they are. I think they are. The fact of prescription to be realized on Amazon.com or in the pharmacy is totally different from the very initial information for the patient that is coming from the physician, and the physician should assess the patient's symptoms and advise patient about the good medication or supplement to be used.
Thank you, Dr. Glowinski. Peter Lawrence, why don't you go ahead with some of the questions that you have or that came in with the Q&A?
Sure. Well, let me ask Dr. Almeida to some more details about with these options of thermal and non-thermal. If you have a SEEP2 patient, I believe it's in the Part 1 guidelines, but it's relevant to your talk today. If you have an incompetent great saphenous vein, the guidelines say, and I think you were part of writing this, that you go down to the lowest level of reflux. So what do you do if the reflux goes from the saphenofemoral junction to the mid-calf or even to the ankle? Do you use thermal, non-thermal, a combination? In other words, how do you handle when you've got a saphenous nerve near that vein down around the ankle? What's your choice of treatment and how do you approach that?
Yeah, thanks, Peter. Yeah, this question's been, relevant since stripping, and it certainly is now. So we actually published a systematic review on this about 2 years ago at JVSVL. Matt Sussman, my fellow, was the first author. 15 studies, all prospective, some randomized control trials, other cohort trials. And basically, there's some themes. Of course, it's very heterogeneous results, like most venous studies, several themes. So if you treat the above knee saphenous only with below knee reflux present, 30–40% of the below knee reflux will correct on its own. However, if you follow them out 3 to 5 years, the recurrence rate is high in that below knee saphenous. So the fate of the below knee saphenous with long-term data, whether it's progression of disease or just failure to treat initially, it'll likely be a source of recurrence. And of course, in the studies, it's mixed because there's ultrasound recurrence versus clinical recurrence, but that's one theme. If you ablate or strip from the groin to the ankle, that is the best way to control reflux and venous recurrence. However, it comes at the expense of saphenous nerve injury. One of the studies, I believe it was Home, they identified there's about 4 patterns of saphenous nerve variation in the calf. So it just may be that bad luck has it that you nail a branch that just is, intimately adherent to the saphenous vein. So my approach, if it's just routine varicose veins, I'll treat the above knee saphenous with thermal ablation and duplex and leave the below knee saphenous. If they recur later, I would use a non-thermal treatment of the below knee saphenous. In ulcer disease, where there is skin damage present, usually already, obviously with an ulcer, there's already an inherent sensory deficit in that area. So a numb ankle from a saphenous nerve injury is not as big as ordeal to the patient. They're interested in wound healing. So I would be more aggressive with ulcer disease, but treat to the lowest point of reflux, that principle, I think it still exists, but exhibit some caution in C2 disease and really just stay maybe just below the knee to prevent a saphenous nerve injury.
Great. Well, that's really a very comprehensive answer. Those of you who don't know, everybody who's giving a talk here today was involved with the practice guidelines, and over several years you get to know each other quite well and the philosophy. And the other thing I remember you talking about, we had a lot of discussion about saphenous vein, was mid-thigh perforators. And when you have, rather than a saphenofemoral junction, your reflux starts at a perforator. And I know you have a particular philosophy. So tell the audience what you do when you have a large mid-thigh perforator identified on duplex ultrasound.
Yeah, I don't know if that is the philosophy, Peter. It's just reality of treating patients. So, the initial guidelines 10 years ago, the 11 guidelines that, of course, Peter G. chaired, it was really emphatic to distinguish between a pathologic and a pathologic and just pathologic perforator versus an incompetent perforator. So pathologic meaning underneath the ulcer bed, and that really was the recommendation to treat those only. However, in practice, this mid-thigh perforator that you're talking about, it mimics the saphenofemoral junction. So it typically presents as 8 to 10 millimeters in diameter at the mid-thigh. And if you ultrasound north to the saphenofemoral junction, the saphenous vein diameter will be normal. If you ultrasound from the perforator distal to the knee, the entire system will be dilated, and that's where the reflux is. So we call that an escape perforator, as opposed to re-entry perforators in the calf, which should not be treated. If you don't treat that escape perforator, and I found that it has to be thermal, we get in there with a laser and hit it pretty aggressively, it will reopen. So it is physiologically the saphenous junction. So I believe even in C2 cases, that's one exception. I think in the new guidelines, we recognize it now that the mid-thigh perforators exist, and there is an indication for it when it's the source of reflux. So yeah, I like the way the new guidelines recognize that there are some variants, such as the mid-thigh perforator as an escape perforator. Sometimes recurrences come from perforators in the calf. Sometimes that's the source of reflux, and sometimes you get in there with whatever technique of choice.
Last question: if you see a huge, let's say not aneurysmal, but a huge saphenous, great saphenous or small saphenous vein to the saphenofemoral junction or the saphenopopliteal junction, if it's 1.6, something like that, 16 millimeters, do you have any different approach? Do you use any ligation or before or ablation, or do you extra compression, or what do you do with a very, very large saphenous vein?
Yeah, so 16 millimeters to me is not huge.
Okay.
When it gets around
30.
the size, when it gets around 30, that's huge. That size, I'd probably ligate it under ultrasound. You can do it through a small incision, but by and large, large patulous saphenofemoral junctions, you would treat just like any other vein, except that a little more aggressive tumescent anesthesia, because you can really shrink the vein with the tumescent, and a little added energy. So for laser, for example, where we would typically treat 50 to 60 joules per centimeter in the body, the saphenous up there, I may go to 100, 120 joules per centimeter, and that would translate to 2 to 3 cycles of RF at the top. I would not use non-thermal for patulous large veins like that. So either high ligation or thermal.
Great, thank you. Suman, you want to take some more questions?
Yeah, and I'm going to hit one right back at you. There's a few about the EHIT, or the new terminology, ART. So there's a question here that wants to know, I guess if you have doing a thermal ablation and you have symptoms and you go ahead and scan and you have an EHIT 1, what would be your recommendation in terms of following in treatment? Dr. Lawrence.
Well, for you said EHIT 1?
Mm-hmm.
Or level 1? We would not. Level 1 is just flush with the junction. Even level 2, there's some debate. When you get to 3 or 4, what we do is we put the patients on an oral anticoagulant, a NOAC, and we follow up by duplex ultrasound until it retracts to the level flush with the deep vein. And that usually takes 5 to 7 days. We do not do full anticoagulation unless it's a level 4, which means the entire deep vein is occluded. And I can't remember when I've seen that. We worry about it, but so if it's more than 50% of the vein or slightly less than 50%, we will use an oral anticoagulant for 5 to 7 days. We've never had a bleeding complication, and virtually all of them retract. This is not DVT where the vein wall, the deep vein wall, has been damaged. They retract very rapidly, and our sense is once they get flush with the femoral vein that we stop anticoagulation.
Right, and there's another question about when you talked about distal DVT after ablation. What is your threshold for symptoms? And then if you do anticoagulation, what is your typical practice in terms of length and when you follow up?
Well, I think when it's in an asymptomatic patient, calf vein thrombosis, I think many of us, and I know you're involved with writing the chest guidelines, but I can remember when it went from no treatment to recommending treatment in certain circumstances. But I think that your options are in an asymptomatic patient, which you would then have done a duplex for some other reason, that in an asymptomatic patient, it's very appropriate to, if you have access to a vascular lab, and do repeat duplex. And only if it gets to the popliteal vein or becomes symptomatic? Is it treated? The other option is to treat it at the time, but that, then the length of time is somewhat debatable. When it's symptomatic, then I think you have a minimum for calf vein thrombosis of 3 months. At least that's what we do for symptomatic below knee calf vein thrombosis. But since we have our own vascular lab, we will watch that patient pretty carefully, and we're always looking for extension. And if it gets to the popliteal vein or above, then it's a full treatment as though they have DVT. And then a lot of that depends on if they're hypercoagulable, if they have a history of DVT, that might determine the length of time.
All right, I'm going to pick on you one more time. There's just a question here about clarification of the class 3 and 4 ART. If we're not routinely scanning, which the guideline says we shouldn't post-ablation, so it's really then only patients who are symptomatic and then you find it that you treat. Is that true?
That's true for thermal ablation. The key, I think, here is, and there have been a couple of papers at meetings I've been at recently, in fact, one that I was involved with, looking at non-thermal, particularly commercial foam, and it may be true also with glue, where the incidence of extension into the deep system, if you do routine duplex, was 5 to 8%. So I think most people would say if you have an event that's 5 or 8%, you probably should consider routine until studies are done that show ways to reduce that. So for thermal, asymptomatic, definitely don't need anything done. But if it's non-thermal, then I think that in that case, if you see a level 2, possibly, but certainly 3 or 4, that those patients should definitely be treated.
Great. And Dr. Meisner, I'm going to throw one at you. There was at the UIP meeting a couple of weeks ago, there was some discussion about the issue of obesity, and it comes up in several of our questions. And, preferably we'd like to do the ultrasound examination in the standing position, but there was a good report that actually you see the most effect of obesity on both the deep and superficial veins in the seated position, as in a chair. What has been your experience at trying to elicit this, depending on position?
Venous disease is a disease of gravity in the standing position. And I fail to appreciate how that is helpful at all.
Yeah, I think the point that this one presenter, I just thought I put it, because obesity is coming up in some of these questions, is that we see the most effect of backflow in the seated position. And I know myself, trying to get our sonographers to do it in the standing position is a big ask. So I didn't know if there was anybody who had experience with that.
And I would just, I would caution with that too, is we're all out here to improve quality of life and in patients with C2 disease. And there is plenty of evidence out there that morbidly obese patients just don't do as well and improve as much prior to weight loss. And, it's, particularly with everything that you have available now, to say I'm going to do a suboptimal study so I can prove that this patient has reflux, and rather than getting them, on any of the options available now, which they're certainly going to get more short-term benefit from and more long-term health benefits than identifying reflux in a sitting position and ablating their saphenous vein. That defies logic to me.
I understand. All right. There's a couple of questions that I want to answer in terms of high ligation and stripping. This was for my section from SVT. I'm not a surgeon. The recommendation is that surgery can be used, but it doesn't prevent the VTE. So I'm going to actually ask our moderator who got off the hook, Dr. Peter Glavitsky, what would be his standard of care? If you have a patient who has a SVT approaching the junction, who may not want to take anticoagulation, what would your approach be?
Well, I think that's probably a single very good indication for a high ligation just to prevent extension of the thrombus. But in general, we certainly would treat these high saphenous thrombosis with anticoagulation. But if there is contraindication to anticoagulate, or the patient had previous bleeding on anticoagulation, then I think a high ligation and removal of thrombus, as we used to do quite frequently 20, 30 years ago, that's still, I think, a good option.
Great, thank you. There's a question here that I'll take about the use of D-dimer in order to evaluate superficial vein thrombosis. Actually, D-dimer's never been validated for superficial vein thrombosis. So unfortunately, although it may be positive in many patients, it hasn't been used as a screening test as we do for DVT in PE. There's another related question. So Dr. Lawrence, we talked about ART after thermal ablation, mostly about DVT or EHIT. This kind of hits both of us. There's a question about what do we do about SVT after ablation, whether it be thermal or non-thermal. Do you have any protocol that you follow?
Well, I think that there are two parts to SVT, and that is the treated vein and also tributaries. I have a pretty good experience with using Varithena commercial foam. And what we've noticed is that the worst symptoms are sometimes superficial thrombophlebitis in tributaries, because as you put it up the saphenous vein, it goes through the path of least resistance, and that's often the tributaries. And some of those get very inflamed to the point where it's superficial thrombophlebitis. And we do one of two things. We either do a small little IND, or we put the patients on anti-inflammatories. So superficial thrombophlebitis is, in my experience, far more common because of the fact that foam goes into the tributaries. When it occurs in the saphenous vein, as Dr. Almeida said, when you get into a really big saphenous or small saphenous vein, even if it's effective in closing the vein, occasionally you have a large, dilated, tender vein. And I think most times with a little bit of xylocaine and we use a no-core needle, 18 gauge, which is not, it's like a 11 blade, except it doesn't keep enlarging. And we use a no-core needle with ultrasound guidance. And if you just express the entrapped blood, I think that symptomatically patients get much better. So we use what we call releases for both tributaries and for the great or small saphenous vein if it gets very inflamed and if it doesn't respond to anti-inflammatories. But I'd be interested in what the rest of the people in the group who treat veins, what they do with superficial phlebitis of either the treated vein or the tributaries.
I'm going to ask one last question to Dr. Monica Glowicki. If you're able to obtain MPFF or these other effective ones, how long should a patient try these before they might see an effect with decreased pain and swelling? What's been your experience?
So the efficacy is shown after a couple of days up to 2 weeks, and it was very nicely assessed in the huge chronobiology study, which was performed in Hungary by Menier. And actually, at 1 month, you observe truly the improvement in around 70 to 80% of patients.
Very good. Dr. Peter Glowicki, I'm going to hand it back to you to take any final questions.
Thank you very much. Well, we still have a lot of questions, and I am sure that our presenters will answer them in writing. I'm asking Monica Glowicki again because we had several questions about these medications. Like Dr. Hingorani wants to know whether you would suggest diosmiplex as compared to other diosmin, and what is the difference between diosmin and MPFF and diosmiplex?
So we had a huge issue with diosmiplex because there is absolutely zero studies with this compound. So I cannot provide any data. There was no comparison with diosmin or any other compound. And the difference between the diosmin and MPFF, it is diosmin is a part of MPFF, 90% precisely, and MPFF has this difference in class that this is a micronized flavonoid. So that is extremely important because truly this is doubling the bioabsorption of the medication. So that's shown pretty nicely also in the clinical results because diosmin has certainly the efficacy, but compared to MPFF, this efficacy is around 30 to 50% less.
Thank you. And maybe one more question to Jose Almeida. Dr. Ravi would like to know if he should use laser or radio frequency. What do you prefer?
So I have both in the office. For me, a run-of-the-mill great saphenous vein, 40 centimeters, no twists and turns. I think radio frequency, and we showed this in a trial many years ago called the recovery trial, comparing laser to RF, that the inflammation early on is a little less with radio frequency. So we tend to prefer that. Since the longer heating elements came online, it's also a little quicker now than laser. I use laser more for complex anatomy because the energy comes out the end hole versus radio frequency where you need a long heating element. So you can get into short segments, perforators, just more complex anatomy with a laser vein of the popliteal fossa, for example, which would be tough with RF. And the other thing is you can, I think dosing the energy is easier with laser. If you have one of these ginormous veins that we were talking about earlier, that you really can deliver more laser energy just by increasing the wattage and pulling back slowing down the pullback and getting up to 80, 90, 100, 120, 150 joules per centimeter if necessary. So laser more versatile, radio frequency a little less inflammation early on post-op, but they're both very effective.
Thank you very much.
Dr. Glowinski, could I ask Dr. Meissner one quick question? Mark, there was a question here about superficial and deep venous reflux, which we often see when patients with varicose veins get duplex ultrasound. The question was, if you correct the superficial reflux and ablate the superficial vein, can or does the deep venous reflux improve?
Well, it certainly can. The most common reason is if you have reflux in the common femoral vein and it's refluxing through the saphenofemoral junction into the saphenous vein, you ablate the saphenous vein and that will go away. But I think it also that there is reasonably good data that some proportion of deep venous reflux, not all, will improve with taking care of the superficial system. And not in most, in most of the pivotal trials for superficial venous disease, and in most of the early, that is ESCAR, not EVRA, the deep veins weren't really looked at very much, and people still got a benefit from it. In EVRA, they did look at the deep veins. But I think the point is that deep vein reflux in the appropriate, properly selected patient should not be a contraindication.
Thanks.
Jose Almeida, there are a couple of people who would want to know if in your video you used the physician compounded foam or you use the polydocanal endovenous microfoam, and can we use either?
So the new guidelines show that this, let's call it a myth, that you need to use physician compounded foam, you need to use CO2. that it is just as safe with air. That's what the data shows. That's what a lot of Europeans do. That's what I do in the office, just air-based foam, usually 4 of air to 1 of a liquid, and back and forth to sorry technique. And that's what we've always used. The caveat I would say there is we do not let the patient get up and perform a self-Valsalva right after the procedure. We let them sit around for 5 or 6 minutes, because we do know that the foam ends up in the right atrium in virtually everybody. And it's just a shunting from the right to the left where the event may occur going up the carotid artery and a TIA or stroke. So, but it's safe. I'm comfortable that it's safe. Yeah, I use PCF all day long, position compounded foam with air.
Thank you very much, Dr. Almeida. I think we will have to close our program. I'd like to thank once again to all our presenters. We heard excellent presentations and we had good discussions. I would like to ask the presenters to write to those attendees who ask questions so that we answer all the questions that came in. Thank you again, Dr. Mark Meissner, Dr. Andrew Obi, Dr. Monica Glowicki, Dr. Jose Almeida, Dr. Peter Lorenz, and Dr. Suman Vasan. And thanks to you for joining and participating with us. This webinar has been recorded and it will be available at the SVS website in 2 weeks. Have a pleasant rest of the evening.